everyone. I would like to welcome you all to the Lead Endonephro Crosstalk session. I am Batul, the moderator for today's session from the IJCP group, and our topic for today is management strategies for chronic kidney disease in type 2 diabetes. I am pleased to introduce our distinguished speakers who are present here with us today. Well, let us begin with our very renowned endocrinologist, Dr. Piyush Desai, sir. Sir is consultant diabetologist and endocrinologist. Dr. Piyush Desai, sir, is highly experienced diabetologist and endocrinologist specializing in diabetes, thyroid disorders, and hormonal imbalance. He holds an MBBS and MD from Government Medical College Surat, along with a postgraduate diploma in diabetes, fellowship in endocrinology from Lilavati Hospital, Mumbai, and a PG diploma in endocrinology from the University of South Wales, UK. Sir is an active member of the American Association of Clinical Endocrinologists and serves on the Committee of Diabetes, Obesity, and Thyroid Disease Network. Dr. Desai also practices at Desai Diabetes and Endocrine Clinic. He is an honorary endocrinologist at Government Medical College, Surat. Sir is also involved in clinical research, conducting phase 3 to 4 trials in diabetes and endocrinology. We welcome you, sir, at our forum. Thank you so much for being here and accepting our invitation. Moving ahead with our another speaker who is very distinguished, and he's none other than the very renowned Dr. Jagdeep Shah, sir, who is the nephrologist. So Dr. Jagdeep Shah is a highly experienced consultant nephrologist with over 30 years of expertise in nephrology, renal transplantation, and chronic kidney disease management. Sir holds advanced qualification including MD in general medicine, DM in nephrology, and DNB in nephrology. Sir has also served as a specialist nephrologist at King Abdulaziz Hospital in Jeddah, Saudi Arabia. Since 1999, Sir has been practicing in Ahmedabad, affiliated with major hospitals like Rajasthan Hospitals, SAL Hospital, Krishna Heart Institute, and HCG MedSurg Hospitals. Dr. Shah is also actively involved in kidney transplant programs, clinical research, and training junior medical staff. Sir is also a life member of several prominent medical associations, including the Indian Society of Organ Transplantation and Indian Society of Nephrology. So now, without any further delay, I would like to welcome both the speakers at our forum and would like to start with Dr. Desai's talk. So over to you.
Good evening, all of you. And we are going to talk today regarding management strategy for chronic kidney disease in type 2 diabetes. And I'm going to give my perspective from as an endocrine because there may be slightly different perspective from nephrologist point of view, from physician point of view, and from endocrine point of view, because we are seeing type 2 diabetic patient quite early in a stage where actually we can prevent even a complication, or we can stop them early when they are developing this. So first, I would like to give you overview for management strategies that chronic kidney disease is widely prevalent, and glycemic control helps to delay albuminuria and improves outcomes in diabetes with kidney disease. And DKD management requires even lifestyle changes, glycemic control, cardiovascular risk reduction specifically, and for that, even RAS inhibition is compulsory. So AC inhibitors and ARBs are main cornerstone for slowing the progression of kidney disease, and all guidelines recommend them for DKD management unless until they are contained. As far as OHAs are concerned, metformin and SGLT2 inhibitors are recommended at first line treatment in DKD patient for glycemic point of view. GLP-1 are a second line option with potential benefit for albuminuria and majorly for cardiovascular risk reduction, and non-steroidal mineralocorticoid receptor agonist has shown promise in DKD with lower hyperkalemia risk and possibly supporting their adjusting use. So as far as light chain modification is concerned, KDIGO guideline and ADA standards of medical care are showing almost similar result, similar guidelines, similar perspectives of lifestyle modification changes in form of sodium restriction by at least 2 gram or 2.3 gram per day with dash style eating pattern, which is mainly fruits, vegetable, and Mediterranean type of thing. Protein intake should be reduced to 0.8 gram per kg per body weight for non-dialysis patient, but here we have to consider one important thing that our Indian vegetarian patients are not even eating 0.8 gram per kg routinely. So, protein restriction, we have to reduce it wisely. Physical activity, moderate intensity physical activity for more than 150 per minute per week or to a level compatible with their cardiovascular and physical tolerance should be initiated. Weight loss from ADF standard of care suggests more than 5% of weight loss. KDICO guideline doesn't include weight loss because many a times CKD patient, DKD patient are already having cachexia, loss of appetite. So they are not much worried about weight gain or weight loss. They are more focusing on other lifestyle modification factor. But in diabetic association, usually we are dealing with more obese patient. Weight loss is also one of the part. Cessation of tobacco product is accepted by both the guidelines. As far as pharmacological agents are concerned, as I have already told, that metformin and SGLT2 inhibitors are having ACUD risk factor reduction and heart failure risk reduction with decent glucose lowering efficacy. SGLT2 inhibitors are intermediate acting. Metformin is having high glucose lowering action, and both are having very low hypoglycemia risk. Metformin is more or less weight neutral. SGLT2 causes 3 to 5 kg modest weight loss. And cost, though it is written high in this perspective, but I will say in India, it is almost at par with all other watches now, so not that high. While GLP-1 is also having some benefit on CKD progression, but very good agent for atherosclerotic cardiovascular disease with very high glucose lowering action, with less hypoglycemia risk, and a significant weight loss effect. But problem is cost. Cost is high. DPP-4 inhibitor are neutral, they are intermediate in glucose lowering efficacy. Weight loss is again it is neutral agent, but cost is again not high, though it is written high in India. We are fortunate to have such type of agent at quite comparable rate. Insulin, on the other side, can cause hypoglycemia, can cause weight gain. Otherwise, glucose lowering efficacy is excellent, but it is neutral for CKD and CVD benefit or risk reduction. SU, on the other side, again, it is neutral, but again, similar like insulin, cause hypoglycemia risk or weight gain risk. Glitazones are actually potentially benefit for ACVD, but problem is heart failure risk. Glucose lowering efficacy is high, hypoglycemia risk is low, but weight gain is an issue, fluid retention is an issue, cost is low, but it is neutral and actually it also reduces microalbuminuria, so it can be given at different CKD stages, but problem is again fluid retention. Alpha glucosidase inhibitor, neutral as far as kidney and heart is concerned, intermediate in glycemic lowering action, hypoglycemia risk is low, weight loss or neutrality you may find, and cost is not that high. But when we are talking about specific agent like SGLT2 inhibitor, we have EMPA outcome which has shown SGLT2 inhibitor significantly reducing the risk of nephropathy, macroalbuminuria, and creatinine rise. Meta-analysis of 38,000 and above participants confirming SGLT2 inhibitor reduces the risk of dialysis, transplantation, or death due to kidney disease across various levels of albuminuria and GFR. And why? Because this indirectly improves cardiac energy, improves cardiac contractility, improves endothelial function, and reduces fibrosis and oxidative stress. And that's why trial like NAPA CKD and EMPA CKD, where renal protective action is there with or without diabetes, along with cardio protection. As far as RAS blockage is concerned, unless until patient is contraindicated, RAS blockage is compulsory when you want to delay progression of DKD. And it is mediated by bioactive end product angiotensin 2 and aldosterone, causes increase in sodium avidity and vascular tone, glomerular injury and proteinuria, which is now inhibited by RAS blockage, and that also reduces systemic inflammation, cardiac remodeling, AC inhibitor or ARBs. Either of these you can choose because we have data with both the drugs. Clinical practice guidelines suggest either of these monotherapy to be titrated to the maximal titrable dose, and only problem is hyperkalemia that you have to look for, or acute kidney injury more than 30% elevation of serum creatinine, that is you have to look. As far as GLP-1 agonists are concerned, they have direct effect like oxidative stress reduction, inflammation reduction, natriuresis, and reduction in glomerular hypertension. It is having significant indirect effect by managing glycemia, hypertension, obesity, and dyslipidemia, and thereby it is having better effect as far as renal protection is concerned. Combination of GLP-1 with other agent causes better reduction of HbA1c when it is combined to metformin and SGLT2, and this combination will also causes less hypoglycemia. It may mitigate weight gain from insulin and sulfonylurea. Additional CV protection with this atherosclerotic event is reduced when you are paired this agent with SGLT2 inhibitor, and it gives basal insulin taking patient a good post-prandial glucose control. Residual cardiovascular and renal arrest is still there despite of whatever treatment I have described in form of GLP-1, SGLT2, metformin and RAS block. That intensive glucose control reduces risk of albuminuria, that is evident. Combining GLP with SGLT2 with AC inhibitor is guideline recommended strategy, and Credence and DAPA CKD trials show that 10% of the patient on RAS blockage and SGLT2 still experience CKD progression or kidney failure. So this suggests that either in this patient, risk of CVD progression or CKD progression is high despite of all possible treatment, and we need more agent, and there come finerenone. So now finerenone is a fourth pillar. It is approved by US FDA in 2021. It reduces risk of sustained EGFR decline, end-stage kidney disease, non-fatal myocardial infarction, hospitalization of heart failure, and cardiovascular death in adults with CKD and type 2 diabetes. It inhibits aldosterone at the mineralocorticoid receptor to prevent receptor overactivity. It reduces inflammation and fibrosis, which lead to kidney dysfunction and cardiovascular disease. So, after all these things, the KDIGO guidelines suggest that lifestyle modification always important, but when you are controlling glycemia in diabetic patients with nephropathy, metformin SGLT2 first, followed by GLP-1, followed by all other agents. RAS blockage to maximum tolerable dosage. For hypertension, you can step up to maximum doses. If required, you may add CCBs or other diuretic depending on the fluid retention MPP target. But MRA, especially non-steroidal MRA, is also advisable for glycemic friendly point of view as well as cardiac failure point of view as well as DKD progression. And statin therapy, which is moderate to high intensity statin, are compulsory to treat such type of patient to reduce CV risk. With this, I would like to end my lecture.
Thank you so much, Dr. Desai, for your insightful talk that you have shared with us, and by sharing your PPT presentation with us and for making our viewers understand about it in such a better manner. So now we would be moving ahead with Dr. Jagdeep Shah's talk. So, sir, putting your PPT on screen, and there we go.
Good evening, friends. Like Dr. Piyush has made my life easy by lining out the algorithm for managing diabetes with chronic kidney disease. Basically, the management of diabetic kidney disease, as described by Dr. Piyush, remains the same, but there is some different perspective from a nephrologist. So, CKD in type 2 diabetes, there are four tier approach. In first tier 1 and 2, you have lifestyle changes which already has been described, like weight reduction, cigarette smoking, alcohol intake reduction, optimal weight management, and individualized blood pressure and diabetes control. This is tier 1 approach. And tier 2 approach, these are the standard medicines which are like well accepted and gold standard for treatment of diabetic kidney disease, that is RAS blockade, SGLT2 inhibitors and statin. So this tier 1 and tier 2 approach should can be done by all physicians. Then comes the tier 3 and 4 requires primary and secondary care physician in coordination. So life tier 1 is the lifestyle changes, individualized glycemic control, blood pressure management is the key component of this care because especially in India, the blood pressure causing diabetic kidney disease progression is more than the diabetic itself. These elements have been integral to standard care in all clinical trials also. So therapeutic intervention for kidney and cardiovascular disease outcomes benefit from these foundational approaches. So these remain same for all the trials and all the management. Regarding the hypertension management, accurate blood pressure measurement is crucial for diagnosing hypertension and for monitoring the treatment following the guidelines. Standardized BP measurement differ from routine measurements by an average of 13 millimeter with a wide range of, but if um, pharmacological treatment threshold depend on diabetes, what kind of diabetes, duration of diabetes, age of the patient, stage of the CKD, and whether patient has albuminuria or not. So these all factors will decide like what optimal blood pressure for the patient. So blood pressure control is vital for slowing CKD progression. When patient has albuminuria, then the target would be less than 130/80. And if the albuminuria is not there or patient is on dialysis with stage 4 and 5, then blood pressure control should be less than 140/90, little bit liberal than the earlier one. So those patients who are albuminuric, their blood pressure control should be tight. And ACE inhibitors are the first line antihypertensive agents. And ARB is recommended when ACE inhibitors are not tolerated. And these has to be stepped up and maximize the dose, tolerated dose. For treatment resistant hypertension, you can add thiazide diuretics to improve the blood pressure control. As already been told, RAS inhibitors reduce the CKD progression by 16 to 20%, but may leave some residual risk. So we have to titrate the ACE inhibitors or ARB doses to the maximum tolerated levels, and with monitoring of serum potassium and serum creatinine. So monitor the electrolytes and EGFR before and 1 to 2 weeks after the starting of RAS inhibitors. So if potassium is less than 6, then continue RAS inhibitors and continue low potassium diet at advice. And if GFR falls more than 30%, then we have to hold the RAS inhibitors and manage the blood pressure with other agents, and then can be reintroduced with the lower dose also. RAS blockade slows CKD progression, but almost 40% of the patients still meet primary kidney endpoint. So 40% of patients still remain without benefit when you give only RAS blockade. Recent SGLT2 inhibitor trial showed 30% reduction in disease progression risk, also cardiovascular risk and mortality. So if and these patients who are on SGLT2 inhibitors, they have an average 3 millimeter lower systolic blood pressure, which also helps in kidney protection. SGLT2 inhibitors are recommended for all CKD patients with type 2 diabetes and EGFR more than 15, regardless of the etiology of CKD. So lipid lowering therapy recommended using statin as optimum dose for prevention in most patients with type 2 diabetes and CKD. And if patient cannot tolerate statin, then ezetimibe may be given in place of statin. 1 millimeter per reduction in LDL cholesterol reduced the cardiovascular events by 21%. But as eGFR goes down or declines, then the benefit is not seen as pronounced as it is in early stages, and this benefit is not seen in patients who are on hemodialysis because there are other atherogenetic factors also in patients who are on dialysis. Post kidney transplant lipid lowering therapy significantly reduce the major cardiovascular events because the morbidity and mortality post kidney transplant, one of the important factors is cardiovascular event. This, by giving lipid lowering therapy, you have you have good chances of reducing the major adverse cardiovascular events or delaying it. And recommended targets are total cholesterol less than 4 millimole, non-HDL less than 2.5, and LDL less than 1.8 millimole per liter. So first line therapy is atorvastatin dose adjustment, and if EGFR is less than 30, then you have to reduce the dose, and you watch for the side effects of statins. And if it is a statin intolerant patient, then azitimide or pempoic acid may be used. Tier 3 approach, where SGLT2 trials has already been discussed, 10% of the patients still will reach end stage or primary kidney endpoints, and 7% which reach cardiovascular endpoint despite this treatment with standard blood pressure control, glycemic control, and optimal RAS blockade. This indicates that even with tier 2 treatment, there is significant residual risk remain in both kidney disease progression and CVD. This highlights the need for additional agent for managing this type 2 diabetes with CKD. So, suggested intervention may include intensifying therapy or consider combination treatment to further reduce risk so of kidney and cardiovascular events. So there comes the role of Finrenon, which is better than a mineralocorticoid blockade, is more robust, and it reduces the aldosterone-induced smooth muscle proliferation, and there is reduced inflammation and fibrosis, which helps in preventing chronic retardation of chronic kidney disease progression. You can see this. There was a Fidelio decade trial where uh, there were around 1,734 patients where they shown 18% risk reduction in primary renal endpoint, while Figaro decade trial where there were 7,000 patients, they demonstrated uh, primary cardiac endpoint reduction by 13%. So now the Fidelity trial was combined pool analysis was done for Fidelio and Figaro trials, and they have shown the renal endpoints to be 23% risk reduction and cardio endpoint to be 15% risk reduction, and the hyperkalemia risk was minimal, and discontinuation due to hyperkalemia was minimal. Regarding GLP-1 receptor agonist, combined with RAS inhibitors, provide both kidney and cardiovascular disease mortality benefits compared to RAS inhibitors alone. So 15% of patients who were on SGLT2 inhibitors with no major differences in treatment effect, indicating that you can combine GLP-1 receptor agonist with SGLT2 inhibitor, and they are compatible, and there is an additional benefit in cardiovascular mortality and morbidity. GLP-1 receptor agonist has strong evidence from multiple trials showing CVD benefits in people with type 2 diabetes, particularly those at risk on established CVD. So, emerging data suggests that there is a complementary effects of GLP-1 receptor analog and SGLT2 inhibitors, and their early combination therapy should be considered in managing type 2 diabetes with CKD to reduce both cardio and renal risk. So you decrease the cardio risk significantly by GLP and reduce the renal risk significantly by SGLT2 inhibitors. So in tier 4, you cardiovascular disease often poses a greater risk than, so usually the patient, if you manage well, the patient usually dies of cardiovascular events before he develops end stage renal failure. So we have to target the cardiovascular disease much more aggressively. And there are risk actuators like KRFE and QRISK3, which assesses the CKD progression and cardiovascular risk. And so if you have a high quiz 3 score with low KRFE, you require tighter blood pressure control, tighter lipid control according to the guidelines. Which are these patients? Those patients who are younger with a higher CKD and CVD risk should have blood pressure control very tight. RAS blocker should be maximized. GLP-1 receptor analog should be added, with close monitoring of side effects and kidney function. So you have to optimize the treatment in terms of blood pressure control, RAS blockade, GLP-1 receptor analogue, SGLT2, and statin, all to be combined early so that you prevent the cardiac and renal endpoints. When you are implementing these therapies, you have to involve the patient and their caretakers. So involving patient along with their caregivers in decision making is crucial, and you have to uh, educate the patient regarding insulin monitoring with capillary glucose level at home blood pressure monitoring, which also improves the medication adherence and the blood pressure control. Supporting primary care teams in implementing all the guidelines like lifestyle modification, blood pressure control, glycemic control, RAS inhibitors, SGLT2 inhibitors, and steroid is essential for improving outcomes in early stage CKD. So, primary care research highlights the need for education on CKD for early detection and intervention using multidisciplinary approach. Specialist team effort support is needed for primary care implement CKD guidelines effectively in clinical practice. So, specialist team guidance is needed for implementing these CKD guidelines. With that, I end my lecture, and now we can start the discussion.
Thank you so much, sir. Thank you for your wonderful insight that you have shared upon from the nephrologist perspective on the topic. Thank you so much for doing that. We would like to welcome again Dr. Piyush Desai, sir, with us in the forum so that we can have the question answers round. So, to both of you, we have heard both of your lectures, both of your talks that you have shared on our platform. And on the basis, we have received few questions. So, the first question would be from Dr. Desai, sir. The question is related to the primary challenges. So, what are the primary challenges in managing CKD in patients with type 2 diabetes, particularly from an endocrinology perspective?
So first of all, to diagnose that patient is having DKD or CKD, because many a times I have seen patients are being checked for the glucose. So even after this care me approach, what we are discussing for years together now, still people are managing their diabetes only on the basis of sugar level. They don't go for urine microalbumin. They don't go for other screening of complications of diabetes. And urine microalbumin and creatinine is not routinely checked by many physicians, primary care doctors routinely to see at least once a year it should be done, which is not done routinely, and that's why it is missed. And when we pick up, patient has already reached to advanced stage of DKD or CKD, and after that actually, there is always once patient is having advanced DKD, the each EFI reduction per year is going on. So ultimately, patient is going to develop end-stage renal disease, and that progression, though we can hold that progression to certain extent, but if we can pick up early, that is always important, which is missed many a times.
Thank you so much, sir. Thank you for your take on this. Moving ahead with the same question to Dr. Shah, sir, what is your opinion on it?
First challenge remains the same, to get the patient early stage of diabetic CKD. And I I know, like Dr. Piyush has already told, that many physicians and primary care physicians, they are not screening the diabetic patient for early CKD. And so somehow we have to generate a public opinion, or we have to educate the public in general so that they know that all diabetic patients are at the risk of developing kidney disease and heart disease. So then they would ask for this test from their physician. Second challenge is those patients who are presenting with moderate CKD or advanced CKD. By giving these multiple medications, the initial decrease in EGFR, sometimes patients do not accept this initial decrease in EGFR, because like once we start the treatment and they will come back with the higher creatinine, they will say with after medicine it has increased. So we have to educate this patient that in long term it is beneficial. And So we will not discontinue this medicine. So, and second problem is the hyperkalemia. If it happens, then we have to educate the patient regarding low potassium diet, and if needed, potassium binding agents should be given.
Thank you so much, sir. Thank you for your opinion on this. Moving ahead with the second question. And the second question is related to lifestyle modifications. So we'll take this question first for Dr. Desai. How do lifestyle modifications play a foundational role in managing CKD, and what specific strategies are emphasized for patients with diabetes?
See, as far as lifestyle modification is concerned, I will say it is very important at every stage of diabetes. Be it just a new diabetes to 5 years diabetes to 15 years diabetic with any complication. Or even after complication has occurred, like patient has already reached to stage 4 CKD or patient is already having one episode of myocardial infarction and stenting is done. At all stages, lifestyle modification is important. Now, what lifestyle modification from DKD point of view is one sodium reduction, because many a times people are not reducing their sodium content. They are always about worry about their sugar, but they don't know how much sodium they are eating. At the same time, managing their potassium level is also important. So, if we ask that if you reduce sodium and you go for DASH diet, many times patients are eating more fruits which contains more potassium. So that potassium restriction, if patient is developing hyperkalemia, then it is important. And not less than that, but a routine exercise, an exercise which is moderate intensity. Now, what is moderate intensity exercise? When patient is walking, patient is running, patient is doing any exercise, patient should have shortness of breath to that extent that he cannot complete his one sentence, or patient cannot talk with other. With that moderate intensity, patient has to walk, work, and along with that cardio exercise, there should be some portion of strength training should be there, not a heavyweight exercise, because we don't ask patient to go for heavyweight exercise when patient is having advanced to diabetic kidney disease, but to certain extent, mild weight and resistance training should maintain their muscle and bone weight. That should be addressed.
Thank you so much, sir. Thank you for your answer on this question. Moving ahead with the Dr. Shah's question. So, we have a question for having an importance on nephrologist perspective. So, the question is related to Tier 3 treatment. How does Tier 3 treatment differ in addressing the residual risk for CKD and CVD compared to the more foundational approaches in Tier 1 and 2?
Dietary approach is the same in type 1 or type 2. It's not different. Basically, the most complex diet pattern you have to write is diabetic kidney disease, where you have to reduce the carbohydrate, optimize the protein intake, reduce the potassium content, and reduce salt intake. So to design a diabetic kidney disease diet is a challenge, and we have our Indian diet is mainly carbohydrate diet. So to change from that carbohydrate diet to a protein diet in a patient with CKD, where general perception is that you have to reduce the protein intake, so that becomes a challenge to explain to the patient that we are not eating the normal requirement of protein, which is zero point 0.8 to 1 gram per kg. If we balance that, I think, and if without salt restriction, the blood pressure will not come under control, and the efficacy of the antihypertensive medication, especially the RAS inhibitors and ARBs, are significantly improved if you restrict the salt at the same time. And they will not act if the sodium intake is high, then the effect of ACE inhibitors and ARBs will be very mild, or there will not be any significant effect. So, salt restriction, optimal protein intake, optimal, so 30% is a carbohydrate diet, and fiber intake with, as Piyush has already told, 150 minutes of exercise per week with strength training is essential for maintaining the overall health of the patient. But sometimes it does happen that the patient restrict diet to a such an extent they lose muscle mass, and the creatinine apparently is down, which does not reflect improvement in kidney function, which is usually done with Ayurvedic treatment, and those they restrict too much of a diet. So that we need to educate the patient regarding the efficacy on maintaining the muscle mass with maintaining the serum creatine. That helps.
Thank you so much, sir. Thank you for your opinion on it. Like when we're talking about diet, so definitely carbohydrate and protein diet, we have it all. But we would like to take Dr. Desai's opinion also on this matter of question about the diet perspective. So, sir, what is your take on this?
See that as I also put very strong point that patients are not eating protein properly, and then we go for protein restriction. So that is very important point. At the same time, I would like to say we have to allow sometimes some carbohydrate which we usually restrict when patient is diabetic, because they are having calorie loss. Many times they are not eating properly, they are not digesting properly because gastroparesis and everything is also going on. So we have to balance, and if required we put patient on insulin therapy so they give proper anabolic action and we can control sugar better. So definitely a diabetes patient with kidney disease diet, to design diet is difficult, but somehow we have to find out the middle way. So we are not harming the kidney, at the same time we are balancing glycemics.
Thank you so much, sir. Thank you for your opinion on it. Moving ahead with the last question before we conclude the talk here. So, the last question for Dr. Desai is: how can patient engagement strategies be improved to ensure adherence to complex CKD management regimens, including lifestyle and pharmacological interventions?
First of all, I would say guidelines are very important, and I think we have very good and nicely designed guideline by KDGO as well as ADA. And for cardiac point of view, I would say ESC guideline also, the European Society of Cardiology guideline. So now guidelines are very clear that what should be your approach. So now the second part is to make patient as well as doctors and grassroots level aware regarding all the guidelines so we can follow it properly. Because see, there things are complex, but if you go step by step, if you assess patients step by step, then it becomes easy. So there are few investigation that should be mandatory, at least a yearly visit like HbA1c, lipid profile, creatinine level, urine album creatinine ratio, as well as eye and feet checkup. These are the basic things should be followed to each and every diabetic patient. If you find anything abnormal, then it should be repeated at 3 months or sometimes at 6 months, depends on the severity. That will prevent, actually that will give you idea at early stage of complication, and that will prevent further progression of that complication. And third thing, as far as choosing medicine is concerned, it should be always a precision medicine. In today's world, we are not giving blanket treatment to all. So though we discuss RAS inhibitor, SGLT2 inhibitor, we have to find out patient, because sometimes you may have to stop RAS inhibitor. Sometimes with urine infection, though it is good drug, we have to stop SGLT2 inhibitor. So it should be done with the precision medicine, with following all the guidelines possible. That will make the complex situation straight.
Thank you so much, sir. Thank you for answering that question. And moving ahead with the last question for a nephrologist perspective. And the question is related to the pros and cons for introducing Fineron as a fourth pillar in CKD treatment strategies. So, sir, your take on this, Dr. Shah.
Yeah. So Fineron as a fourth pillar is now well established therapy, and it should the benefit starts as early as when patient has microalbuminuria. So it should be targeted at that level so that patient has long term benefit. I know the cost right now prevents widespread usage of Fineron in many patients, but if patient can afford, and if you convince the patient that this is helpful in preventing the cardio-renal events, then it should be introduced at this stage as microalbuminuria stage, and uh, the benefits are very clear. So it is just question of implementing and educating the patient. and you need to have conviction about it.
Thank you so much, sir. Thank you for your valuable opinion on the question asked. And I would really thank all our viewers for their ardent participation that they have shown by staying tuned throughout the session and for putting across such interesting questions to us. And at the outset, I would also thank both of you for your valuable time, for your contribution, for your wonderful insights, with your enriching experience that you have shared on our platform by your PPT talk that you have presented, and for making our viewers understand about it and educating them, most importantly, and for creating awareness. Thank you so much, sir. Before we conclude, any last take home message from your end? Dr. Desai, first you go.
I will say find out all complications at early stage and treat them aggressively before it worsens.
Thank you so much, sir. Dr. Shah, your last take on it.
Yes, education of primary care physician and education of public in general regarding the possible effects of diabetes on various organ system needs more emphasis, and it should be more widespread, so that will create more pool of patient who can be benefited, and we can introduce these newer therapies which are helpful in long term cardiorenal benefits.
Thank you so much, sir. Thank you. We have had wonderful time this evening with all the valuable insights and knowledge that you have shared. We hope that this particular informative session would definitely be helpful for our audience who were here with us throughout the session. So thank you so much, sir. With this, we would like to conclude the session here for today. Until next time. Thank you.